In this video, we'll be discussing oral pathology doubts. So starting with corrugated collagenous rings surrounding lymphocytes and plasma cells and walls of inflammatory cysts are called, and your options are option A, Rushton bodies, option B, hyaline bodies, option C, Hobble-Jolly bodies, option D, papenhema bodies. So we'll immediately rule out Hobble-Jolly bodies, which are seen in sickle cell anemia, and papenhema bodies, which are seen in routine blood stains. The confusion is between Rushton and hyaline bodies. Out here, we'll go with the option of Rushton bodies. Now, as you all can see in the diagram, Rushton bodies are eosinophilic, linear, straight or curved hyaline bodies. Now, they are being called hyaline because they have a uniform or a glassy appearance. They are thought to be brittle in nature, and the nature of their origin is keratin. Now, though the term has been used interchangeably in Schaeffer's, it's better to go for the specific name, because in pathology there are several other hyaline bodies like your Russell bodies, which are found in plasmacytomas, multiple myelomas, and periapical granulomas and periapical cysts. Now, Russell bodies are also eosinophilic homogeneous immunoglobulin containing inclusions found in plasma cells. So they need to be differentiated from your Rushton bodies, and this can be done with the help of PAS positive stain. Moving forward to the second question, which says multiple oral papillomas may be a feature of, and your options are focal dermal hypoplasia syndrome, multiple hamartoma and neoplasia syndrome, Bowen's disease, and D, acanthosis nigricans. The correct answer here is B, multiple hamartoma and neoplasia syndrome, the other name for which is Jorgon syndrome. The classic features are pebbly lesions and fibromas in oral cavity, facial trichlemomas, angiety, thyroid, CNS, and musculoskeletal abnormalities. This is an autosomal dominant condition. It is also cutaneous marker of breast cancer. Now, our option A, focal dermal hypoplasia syndrome. Now, in this also there are papillomas, but these papillomas are present around the nose, lips, anus. Along with it, we have dermal hypoplasia, telangiectasias, foot anomalies, and ophthalmic anomalies. Bowen's disease is squamous cell carcinoma in situ. Acanthosis nigricans is a condition of the skin characterized by dark, thick, velvety skin in folds and creases. Our third doubt is most common tumor in AIDS is, and your options are A, Kaposi's sarcoma, B, non-Hodgkin's lymphoma, C, Hodgkin's lymphoma, D, squamous cell carcinoma. Now, the correct answer here is going to be B, non-Hodgkin's lymphoma. So, with the introduction of antiretroviral therapy, it was noted that prevalence of Kaposi's sarcoma reduced substantially, making non-Hodgkin's lymphoma the most common neoplasm in AIDS. Notwithstanding that, Kaposi's, non-Hodgkin's, and cervical cancers are three cancers which are known as AIDS-defining malignancies. So you will have to choose your answer according to the options given. Our next question is, oral lesion seen in hepatitis C is, and your options are A, lichen planus, B, leukoplakia, C, erythroplakia, D, gingivitis. The correct answer is A, lichen planus. So as you all know, hepatitis C is a viral disorder, and extrahepatic manifestations usually represent the first sign of hepatitis C infections. And oral lichen planus is a chronic, lesions are chronic, which rarely undergo spontaneous remission and have a potential malignant potential. Now, the pathogenesis for oral lichen planus is cellular immune response due to extrinsic antigens, altered self-antigens. So your hepatitis C virus acts as a extrinsic antigen which triggers the cytotoxic T cells to cause apoptosis of oral epithelial cells, resulting in oral lichen planus. Moving on to the fifth question, which says increased incidence of carcinoma is observed in, and your options are homogeneous leukoplakia, verrucous leukoplakia, nodular leukoplakia, or none of the above. The correct answer here is B, verrucous leukoplakia. Now, leukoplakia, we all know, is a clinical term used to describe white lesions on oral mucosa which cannot be rubbed off. It is subdivided into homogeneous and non-homogeneous based on its appearance. As the name is suggesting, homogeneous leukoplakia almost have a negligible malignant potential. In the non-homogeneous category, it is further subdivided into erythroleukoplakia, which include where the white patch is intermingled with bright red velvety plaques, nodular leukoplakia, where the white plaque is elevated and you see presence of several nodules, verrucous leukoplakia, which has a very verrucous, rough, corrugated surface, and speckled leukoplakia. Out of all this, verrucous or the proliferative verrucous leukoplakia is the most aggressive form with a strong potential for malignant transformation. It has been known to transform into verrucous carcinoma, conventional squamous cell carcinoma, and papillary squamous cell carcinoma. Now, the next question is, autoantibodies, anti-RO and anti-LA are completely absent in. Your options are option A, systemic lupus erythematosus, option B, Jorgon syndrome, option C, diffuse scleroderma, and option D, rheumatoid arthritis. Now, the correct answer here is going to be diffuse scleroderma. Now, before we come as to why we've chosen this answer, let us understand what is antibody RO and anti-LA. So the RA-LA system is actually a heterogeneous antigenic complex which is made up of 3 different types of proteins, a 52 kilodalton RO, a 60 kilodalton RO protein and LA protein, and 4 small RNA particles. Now usually antibodies, anti-RO, which is also known as anti-Jorgon syndrome antigen A antibody, is seen in SLE and Jorgon syndrome along with biliary cirrhosis. Now this is always associated with anti-LA, which is also known as anti-Jorgon syndrome antigen B antibody, which is also seen in Jorgon syndrome. The two of them share a pathological characteristic. They're also seen in interstitial lung disease and rheumatoid arthritis. Now, why we chose diffuse scleroderma? The diagnostic antibody for diffuse scleroderma or systemic sclerosis are your anti-nuclear antibodies, which include anti-topoisomerases, anti-centromeres, and anti-RNA polymerases. Coming to our 7th question, which says, which of the following structures are not affected in leprosy? Your options are option A, gingiva, option B, tongue, option C, hard palate, and option D, soft palate. The correct answer is option D, soft palate. So, leprosy, as we know, is a bacterial disease caused by Mycobacterium leprae. And as you can see in the picture, the oral lesions are small tumor-like masses called lepromas. The most common site of lepromas are tongue, lip, and hard palate. So your tongue and hard palate are ruled out. Now these lepromas or nodules can break down and ulcerate. Gingival hyperplasia is a common feature in leprosy. So your gingiva is also ruled out. Other manifestations include paralysis of facial and maxillary division of the trigeminal cranial nerve. The premaxilla, its growth is affected in children, which again will include your hard palate. And the teeth will show circumferential hypoplasia and extremely short roots. Now the next question is Jorgon syndrome and Zika syndrome same? If not, what is the difference? Now, in Schaeffer's, Zika syndrome has been used synonymously with Jorgon syndrome. However, note that there is a slight difference. As we know, Jorgon syndrome is an autoimmune disorder which is characterized by a triad of keratoconjunctivitis Zika, that is dry eyes, xerostomia, dry mouth, and rheumatoid arthritis. Now, if out of the 3 symptoms only dry eyes and dry mouth are present, then we use the term primary Jorgon syndrome or Zika complex. And if in addition to dry eyes and dry mouth, you have rheumatoid arthritis, SLE, polyarthritis nodosa, polymyositis, and scleroderma, then it is known as secondary Jorgon syndrome. So to conclude, I will say that your primary Jorgon syndrome is same as Zika syndrome. The ninth question is telomerase activity is more in, your options are A, germ cells, B, stem cells, C, somatic cells, D, senescent cells. The correct answer here is A, germ cells. So to explain this, first let's understand what are telomeres. Telomeres are tandem DNA repeats at the chromosomal end which provide chromosomal stability. And at every time a cell replicates, there'll be a loss in the telomere length. As you can see, this is illustrated in this graph. Now, telomerases are nothing but reverse transcriptase enzyme which adds telomeric repeats onto the chromosomal ends. So, out of the given options, the somatic cells and senescent cells, because somatic cells have only limited number of cell divisions and senescent cells do not have any cell division. The senescent cells are the cells where the cell division has ceased. They will have extremely low telomerase activity. Now your germ cells, because they divide many times, and in the germ cell, high telomerase activity will ensure maintenance of telomere length at maximum during gametogenesis, despite repeated division. So germ cells are known to have the highest telomerase activity. Now stem cells, theoretically, because they also have the potential to differentiate into any specialized cell type, have a high telomerase activity, but particularly the embryonic stem cells are known to have the highest telomerase activity. The adult stem cells have a slightly lower telomerase activity as compared to germ cells. Only when they enter their proliferative state, your committed hemopoietic progenitor cells, then the telomerase activity increases. So you have to look at the options while marking this answer. Our 10th question is, the most ideal explanation for recurrence of odontogenic keratocyst is, and your options are A, increased mitotic activity of the epithelial lining, option B, friability of the epithelial lining, option C, presence of satellite cysts or daughter cysts, and option D, continued proliferation of cell rests of dental lamina. So the correct answer here is going to be option D, continued proliferation of cell rests of dental lamina. Now let's look at all our options. So the first option says increased mitotic activity of the epithelial lining. So in this increased mitotic activity of the epithelial lining is related to its malignant potential of OKC, of an OKC transforming into a ameloblastoma or something like that. It's not related to its recurrence. The second option is friability of epithelial lining. This and the thin thin cystic wall and its friability make it difficult to remove the OKC in C2 in whole. It's not related to its recurrence rate. Now the third option says presence of satellite cysts and daughter cysts. Now it was found that, as you can see in this diagram, that the connective tissue wall contain certain islands of cystic epithelium. Now these are thought to represent the ends of the folded ends of the lining epithelium of the main cystic cavity when it was cut in cross section. So it was a processing error, as you can see in this rough diagram here. The last option, that is continued proliferation of cell rests of dental lamina. So Brown in his study found that presence of additional remnants of dental lamina in the region where the cyst was the main cause from which the new cyst developed. Now the 11th question is spatial nerve paralysis is common with, and your options are option A, pleomorphic adenoma, option B, epidermoid carcinoma, option C, Wathen's tumor, and option D, lymphoepithelial carcinoma. The correct answer here is going to be option B, epidermoid carcinoma. Now look at the options. This is the only malignant neoplasm. So the malignant salivary gland neoplasms are known to cause local pain, facial nerve paralysis, fixation to deeper structures, and local invasion. So because of the options given, we'll go for mucoepidermoid carcinoma. The 12th question is immunomodulators used to control B cell activity in Jorgon syndrome act against, and your options are option A CD22, option B CD26, option C CD24, and option D interferon gamma. So the correct answer here is CD22. Now, to fully understand this answer, you must go through the pathogenesis of Jorgon syndrome. So, B cells are implicated in pathogenesis of Jorgon syndrome. They are known to generate autoantibodies, produce cytokines, and even result in apoptosis of epithelial cells in the salivary and lacrimal glands. So the immunomodulator used to treat this will target the B cells. Now, B cells are known to express CD22, particularly that is the cluster of differentiation 22. It is a transmembrane protein which is expressed in mature and marginal B cells. So if you remember, your immature B cells are in the bone marrow, whereas we need to target the cells in the lacrimal glands and the salivary glands. So these cells express CD22, and CD22 helps in entry of B cells into the lacrimal and salivary glands. So your immunomodulators will downregulate the expression of this CD22. So with this, we finish our first lot of doubts. I hope it was helpful. Thank you.